Good evening, all. We want to welcome you to tonight's webinar presentation, Bracing for Spine Deformity. This is a collaborative presentation by the Scoliosis Research Society, commonly referred to as SRS, and the Society on Scoliosis, Orthopedic, and Rehabilitation Treatment, also known as SOSORT. The SRS, for the past 50 years, has been the premier spine society in the world. It includes over 1,300 members that are spine surgeons, scientists, research, physician assistants, orthotists, and a variety of other people that are interested in the healthcare of spine deformity. They seek to foster the optimal care of all patients with spine deformities. 15 years ago, SOSORT was founded. The general name of this society is to foster conservative care and early detection and all the elements that go into make sure that we can provide truly optimal care for patients. They encourage multidisciplinary teamwork, including all members of the care society. Tonight's presentation will cover a variety of different topics. First will be the fundamental question by Dr. Weinstein: when does bracing work in spine deformity? Luke Stikeleather will take us through so many braces, so little time. We will end with Dr. Fuller answering the question, when do we stop bracing? There will be an opportunity for questions and answers at the end of the session. If you go to your navigation bar and see the question and answer folder, you can post your questions there. You also have an opportunity to upvote for these questions so that we can determine what's the most important ones that we want to make sure we answer, and they all will be answered at some point in time if we can't do it this evening. My name is Joe O'Brien, and I am the President and CEO of the National Scoliosis Foundation. I am also a scoliosis patient who has had 6 spine surgeries, and we have 15 family members with scoliosis. More importantly, I am honored to be an honorary fellow member of the Scoliosis Research Society and a co-founder and past president of SOSORT as well. I would like to tell you that tonight's presentation will be recorded, and it is available at the link that you see at the bottom of this slide. These are the disclosures for the presentations tonight. So without further ado, I would like to introduce Dr. Stuart Weinstein from the University of Iowa. He is an orthopedic spine surgery that's perhaps had the most incredible research in the past 40 years on the natural histories and long-term outcomes of the spinal deformities. We welcome Dr. Weinstein answering that question: when does bracing work in spine deformity?
Hello, I'm sorry, I lost my connection there. Thank you for coming, everyone. So the fundamental question about whether braces work is one that has vexed physicians for many years. The expectation of you as a parent or a patient is that when your physician prescribes a brace, that it will prevent the curve from getting worse and hopefully prevent the need for surgery. Modern bracing history began in the 1940s in Milwaukee, At that time, there wasn't any of the available modern instrumentation that's used currently to correct deformity, so children who needed surgery had an in situ fusion and wore a body cast for a very long time. Dr. Walter Blount in Milwaukee helped develop the Milwaukee brace, which was used to shorten the time for casting after surgery. And subsequently, the Milwaukee brace was used as a non-operative treatment for scoliosis without any evidence that it actually worked or was effective at all. When I began my practice in 1976, the Milwaukee brace was the standard of care, and we followed our patients over a number of years to ask the question, does the brace work? And we found that braces didn't seem to be working, and curves resumed their natural history once the was discontinued. And you can see for larger curves, back here, for larger curves, what they went on to require surgery. We also found that some of the children were having psychosocial problems by the use of a brace, which, as you imagine, is very difficult during the adolescent years when bracing is recommended. In the 1980s, underarm braces became popular, so-called TLSO. These are lower profile, lighter materials. They could be customized, and they seem to offer improved comfort and cosmesis. When we evaluated the results of our underarm braces, we found that they seemed to be failing in a high number of patients. So we wanted to know, is it our bracing efforts that are failing, or is this a general trend around the world? So we did a systematic review of braced and unbraced patients, and we were unable to conclude that braces were effective in preventing the need for surgery. At the same time, in the early 2000s, the U.S. Preventive Task Force on Screening came out with recommendations against school screening because their independent review of the bracing literature was inconclusive, and therefore they felt that if you don't have an effective treatment, that screening is unnecessary. And similarly, the Canadian and British counterparts also recommended against school screening. So at that time, bracing was the standard of care, but we realized it had never been subjected to a rigorous evaluation of either its efficacy or its effectiveness. And when you talk to members of the Scoliosis Research Society at that time, you found polarized opinions. Some physicians thinking it actually does work and you should wear it 23 hours a day, and others thinking it doesn't work at all and should just wait till the patients who progress need surgery. This gave us the opportunity to do a randomized prospective trial sponsored by the National Institute of Health and the Canadian Institute of Health Research and the Shriners Hospitals and several independent hospitals. Does bracing work to prevent the need for surgery in high-risk scoliosis patients? The second question we wanted to answer is, if braces do work, does it matter how much you actually wear the brace, the wear time? The eligibility criteria were the standard criteria used even today to recommend a brace for a child, which is a curve between 20 and 40 degrees in a child 10 to 15 years of age who is skeletally immature. Skeletal immaturity is defined by the ossification over the iliac crest called the Risser sign, and immaturity was defined as Risser less than 2 and having menses for less than 1 year. The study began in 25 institutions in the United States and Canada in 2007. By 2009, we had fewer than the anticipated participants because we found that patients actually wanted a choice. They were unwilling to accept a coin toss to determine whether they would wear a brace or be observed. So a preference arm was added in 2009. Both the preference arm and the randomized arm had the same criteria, the same follow-up. Enrollment was completed in 2011, and the patients were then subsequently followed. In 2013, the National Institute of Health stopped the trial because we were able to show from the data at that time that braces do work, that it would be unethical to continue the trial and not treat children with bracing who are at high risk. This is the data from the trial. The two bars on the left are all the patients, both the randomized and those who were at their own preference. So this is the aggregate data, and you can see that bracing is definitely effective, and this would be what we call level 2 evidence. When you take what we call the intention to treat, or the highest level of evidence, level 1 evidence, it is very clear that bracing prevented the need for surgery in high-risk children. Then to answer the question, does it matter how much you wear the brace? We were able to show that children who wore the brace more than 13 hours a day had a 90% success in preventing the need for surgery. When you look at lower brace wear, this is children wearing the brace 6 hours or less, it was essentially the same as not wearing a brace at all. So hence we could say that wearing the brace for a prolonged duration during the day, in this study at least more than 13 hours, gave a 90% success of avoiding the need for surgery. This was published in New England Journal of Medicine in October of 2013. And so as a parent or a patient, we now had level 1 evidence, the highest level of evidence, that bracing does work and decrease the risk of progression to the surgical threshold, and that it does indeed matter how much you wear the brace. The brace more than 13 hours a day was associated with more than a 90% success. Sorry, we're having a little trouble advancing the slides. We're learning a lot more about maturity in patients today as we continue our research, learning about maturity markers, and some of your children may have their hand x-rayed to determine their maturity. We look at other signs, for example, hip ossification centers, to better determine the maturity status of a child so that we can make better indications for the children who are at high risk. The criteria for who is a high-risk patient still exists today, curves between 20 and 40 degrees in patients who are skeletally immature. But we realize from our research that we're still over-treating patients, and so our research in the future is aimed at how do we better determine who exactly is the patient who needs a brace. And as Mr. Stikeleather will talk about soon, we don't really know at the moment, is there a best brace? If we turn to the next condition, which is Scheuermann's kyphosis, here the evidence isn't so strong. Scheuermann's kyphosis is a deformity of the spine in the lateral plane as you look at a child from the side. The criteria for Scheuermann's kyphosis is that you have wedged vertebrae, at least 3 of them wedged by more than 5 degrees. Scheuermann's occurs in about 5% of the population in boys and girls equally. It presents during the adolescent growth spurt, much as adolescent idiopathic scoliosis does. Many children have some discomfort or pain in their back, aggravated by standing or prolonged sitting or with heavy physical activity. A third of the children with Scheuermann's kyphosis also have mild scoliosis. As the deformity increases, the pectoral muscles can become tight, as can the hamstring muscles. Now, Scheuermann's kyphosis has 2 areas of presentation. As you can see on the slide on the left, this is a Scheuermann's kyphosis in the region where the spine is normally kyphotic. And the slide on the right is a child whose apex is a little bit lower, the lower part of the thoracic spine, where in the normal spine, as you can see in the middle, the spine should be straight. There is one paper on natural history, which we published a long time ago. And what I would tell you is that children with Scheuermann's kyphosis have normal pulmonary function and actually have better pulmonary function unless the curve gets more than 100 degrees. When the curve gets very severe, the chest wall becomes severe, and this can lead to restrictive pulmonary lung disease. When you look at the long-term follow-up of patients with Scheuermann's, they do have back pain, they do have some concerns about how their back looks, and as I mentioned, if the curve gets very severe, they can have restrictive pulmonary disease. But most children, as adults with Scheuermann's, have a very normal life and adapt well to the condition. Bracing is indicated for Schurman's curves, which are above the normal range. So that's a curve more than 50 degrees and less than 75 degrees in a skeletally immature patient. The immaturity criteria are the same for adolescent idiopathic scoliosis, a Risser sign of less than 2 and Menzies less than a year. The wearing programs are basically the same as for scoliosis, more than 14 hours a day, and also accompanied by exercise programs. But the level of evidence to support bracing treatment in Schurman's disease is much lower. It's level 4 evidence. And as someone who's treated patients with Schurman's for over 40 years, I would say that these patients have much more difficulty adhering to the recommended treatment. So to summarize, in adolescent idiopathic scoliosis, we have high-level evidence, level 1 evidence, that bracing works to prevent the need for surgery in high-risk patients. In Schurman's kyphosis, bracing is recommended for high-risk patients, but the level of evidence to support that treatment is quite low. Thank you.
Without further ado, I'd like to present for so many braces, so little time, Luke Stikeleather. Luke is the founder of the National Scoliosis Center. He is a certified orthotist who is known around the world for his expertise in scoliosis. He is specializes in all braces, but particularly with the Rigo Chenau brace, who he had done training actually with both Dr. Rigo and Dr. Chenau. And I would say that he is a very patient-centered orthotist. Now answer the question, what really matters?
Thank you, Joe. Good evening, everyone. So this topic is near and dear to my heart in the whole realm of bracing. The topic was originally so many braces, so little time, and indeed that's very true, that there's just not enough time to go over all of it. So I kind of revised the title a little bit to say, what really matters as you are parents and patients inquiring tonight about the whole realm of scoliosis management non-operatively. I like to say that having scoliosis, like many medical conditions, can be a real challenge. And how we respond to the challenge can make all that difference. So when you've been diagnosed with scoliosis, what really matters? So I want to begin by thanking Dr. Weinstein and Lori Dolan and all those involved in the brace study. It was a monumental effort, and I had the privilege of assisting them with my role on the Bracing Safety Committee. In addition to the obvious published findings that Dr. Weinstein just conveyed, that braces are effective in stopping curve progression, there were some other important observations that I made indicating the importance of the orthotist role, specifically in the scoliosis realm of their education and their bracing competence, as well as the need for research and development of better brace design and improved training. So obviously you can see in this slide that there were a total of 365 braces that were made over several years, a lot of different ones used, and of course everyone wants to know which brace worked the best. The simple answer is to say that it was not the intent of the study, and we don't really know. It's very difficult to do comparative brace analysis. As Dr. Weinstein indicated, these are randomized controlled trials that they were doing. You can't really do that with comparing one brace to another. So my intent is basically to give you a highlight that there are a lot of different braces currently being used. And in this short presentation, I'll go over some of them. They break out fairly easily to some categories, whether they're worn at nighttime, whether they're worn in the daytime, and how they're designed. And so on this slide, you see that there are some different names up there. So we'll go through and we'll give you some specifics on a few of these. The brace type and hours prescribed are quite variable, and they're often driven by the prescribing physician's recommendation. And this recommendation is often influenced by their training, their experience, as well as their interpretation of studies and published guidelines from SRS and so forth. So the Milwaukee brace, as Dr. Weinstein already indicated, was developed in the late 1945 era, and it was primarily initially to treat polio patients. It later was evolved to start treating idiopathic scoliosis, and from there became the brace of choice in managing scoliosis patients. It also is very effective in managing kyphosis patients as well. Due to its superstructure around the head and neck, it was a difficult brace to wear, and eventually over time, as we developed new concepts and ideas, was replaced by the underarm style brace like the Wilmington TLSO. So the DuPont Center in Wilmington developed a system that opened in the front that was a little bit more patient friendly and continues to be used quite effectively there at the DuPont Center. It is followed by physicians who were trained there as they move on to other places. The Boston brace was also developed around the same time, and it was an evolution from the Milwaukee brace. It opened in the back because it was similar to the Milwaukee pelvic girdle. And the concepts were that if we could just get rid of that upper structure, could we effectively treat these curves? And to everyone's surprise, they were able to do that. And consequently, the Boston brace was born and was used quite effectively. And in the study overall was the #1 brace design in the study and is commonly prescribed today as the most commonly used brace. Eventually, in the late 70s, some patients were really unhappy with having to wear braces full time. So they were asking about options. Could they just wear a brace at night? Could they come up with something so they didn't have to wear it during the day? Obviously, we want to minimize the impact of bracing on one's social and emotional state, but this concept came about because a patient refused to wear a brace during the daytime, the prescribed hours. And so the orthotist and patient and a physician developed the Charleston bending brace as the first nighttime brace. Providence brace was developed as a different type of nighttime brace. Instead of emphasizing the bending element, it emphasized the ability to maintain a better alignment and treat two curves instead of one curve that the Charleston typically addressed. The Chanot brace is a relative newcomer in North America starting in 2004. And the versions that we're most commonly using now are really the Rigaud Chanot versions. And this style of brace is very effective, particularly in addressing the three-dimensional nature of scoliosis. We not only have the Cobb angle that we see on the x-ray, but we have the rotational components, and we have the alignment from left to right and front to back. And the Rigaud Chanot brace is catching on quite effectively around the country and is becoming a brace of choice in many centers. So as we said, the Boston style posterior opening brace continues to be most commonly prescribed. Newer designs like the Rigaud Chanot are effectively addressing the three-dimensional correction. But ultimately, the success of any bracing regime depends on the competency of the orthotist, the construction of the brace, and the compliance of the wearer. So our objectives really for the future are to put an emphasis on training and proficiency amongst orthotists. We still have a lot to learn and to improve upon in order to do our part in helping you be successful. There are many parent-patient resources available. Many doctors and scoliosis clinics provide this great reference guide which covers all essentials you need to know about navigating your journey. And I'm pleased to have been involved in writing and editing the section on non-operative management. While my presentation today primarily addresses scoliosis, the core concepts apply to kyphosis and other spinal conditions. Bracing for success really starts with you. Your attitude and actions will have the biggest impact on your journey with scoliosis and kyphosis. Of the thousands of patients I fit with braces over the last 32 years, those with a positive attitude were far more motivated and successful with bracing. As my patient Maisie likes to tell me, I don't worry about what anyone else thinks. I'm doing my best, even when it's difficult. And she did an amazing job. So what we want to tell you is that your attitude has a major impact on that. And it's an attitude not only of accepting the brace, but what you do about learning about that. So choose to become educated and knowledgeable. Your power over scoliosis begins with asking questions. There's a lot of information available. We often rush to consult the internet. The SRS website has a wealth of good patient information that you can trust. When you're searching other sites and sources, be careful and attempt to wisely discern the fact from fiction. In the end, you want the best care of your condition because you want a successful result. In non-operative care, that's defined, as Dr. Weinstein said, as preventing curve progression and hopefully not having surgery. This success is never a guarantee, but it's certainly more likely when you have a positive attitude. You need to build a winning team of players that includes the professionals, your parents, and your peers. Your professional team needs to be the most knowledgeable, competent scoliosis, kyphosis expert you can find. You will regularly meet with them and rely on them to guide and direct you with your program of care. Each one has a unique role and responsibility. Hopefully all of them are positive, passionate, and encouraging. Next slide. As I showed you earlier, there are many different braces being used around the world. Some are expertly designed and function very well, while others are made with the best of intentions, but unfortunately completely miss the mark. Most orthotists are generalists, not scoliosis or kyphosis specialists. Remember that all braces are not the same. Very few orthotists have the depth and breadth of experience in treating scoliosis and spinal disorders. In the end, it's more about competency of the orthotist than the design of the brace. With the help of your professional team, you will develop the right treatment plan that addresses your specific needs and issues. This plan will give you all the details about brace wearing time, follow-up appointments, x-rays, physical therapy, and weaning from the brace. Unfortunately, there is no consensus among doctors on the weaning time or wearing protocol. Your child's compliance is strongly influenced by brace comfort and appearance. They are more likely to wear it if it achieves good embrace curve reduction, it fits well, and looks good. Your role and responsibility is to follow the plan. Be diligent wearing your brace. The number of hours definitely makes a difference. Several new studies confirm the findings of the brace study, showing that patients who wear the brace more hours tend to have the best results. It's our experience that many patients have a brain-body adaptation. That means they get used to the brace in a way that it's easier for them to wear when they wear it more. And that occurs when it's worn at least 21 hours. Next. While the primary goal is to keep your spine stable and prevent progression, an increasing number of patients are getting long-term improvement. When they have active growth, faithfully wear their brace at least 21 hours a day, and regularly see their team and diligently follow the plan, this is much more likely to occur. In addition to the positive coaching and encouragement from your orthotist, therapist, doctor, and nurse, patients who share their experience with family and friends stay on course with less complications and emotional stress. There are a number of good support groups and organizations like the National Scoliosis Foundation that Joe's part of, and the Curvy Girls. So we really encourage you to connect with your friends and with the local groups that can be of encouragement and support to you. Some of our patients have a strong support team, and they invite their friends to come over and have a party. They suggest you share your story at school. You can do a report or a science fair project. Find other patients who've traveled the road before you and who can give you good advice about the whole process. As a quick review, while success is never a guarantee, it's much more likely if you invest time and effort becoming knowledgeable, work to have a positive attitude and realistic expectations, and seek the experts, building a team of scoliosis specialists that help you develop your individual treatment plan. Additionally, find the most competent orthotist who provides the best brace design and diligently follow your treatment plan with the support of your family and friends. Remember, you're never alone on this journey. While your scoliosis will always be part of your life, it does not define you. It's not your identity. So embrace the challenge. It will make you stronger and you will be successful. Thank you. It's been an honor.
Thank you very much, Luke. It's been an honor to have you in answering that question about what really matters. And now we'd like to go to our last presentation for the evening. When do we stop racing? And this will be given by Dr. Fuller, who is an orthopedic spine surgeon at the Nebraska Spine and Pain Center, who is a fellowship trained at the Twin Cities Spine Center and is a veteran of the United States Air Force. Thank you for your service. Dr. Fuller?
Well, thank you for that introduction, Joe. So we've already heard a lot of detail on scoliosis treatment by braces this evening. We've heard about how braces are effective. We've heard about how braces are implemented or constructed, and we've heard about when bracing should be started. And my experience when proposing brace treatment to a patient is that the first question that arises is, how long will my child need to wear this brace? Next slide, please. So the quick answer is when the curve stops progressing. We know that curves progress during rapid growth, so during the adolescent growth spurt primarily, and at skeletal maturity, curves progress very little. Therefore, bracing can be stopped at skeletal maturity. Simple enough. How do we determine skeletal maturity? So there are a number of approaches to this question. The first would be simply chronologic age. Typically, girls are skeletally mature at the age of 15 or 16, boys perhaps 2 years later. But we all know that in the wide in a wide population, there's a lot of variation, and so we can't rely strictly on the calendar to determine when the patient is skeletally mature. Another handy measure is menarche, that is the onset of menses. Typically, we think that 18 to 24 months after menarche, growth has ceased. This is also subject to the wide variation in a population problem, and it's obviously an unhelpful method to determine skeletal maturity in boys. An oldie but goodie in the scoliosis world is the Risser sign. So the Risser sign describes the ossification of the growth plate of the pelvis, and that ossification progresses from lateral to medial along the pelvic bone, the ilium. When the ossification has gone 25% of the way across, we say that's Risser 1, 2/4 is Risser 2, and so forth. When the growth plate is fused all together, that's Risser 5, and certainly the patient is skeletally mature at that time. We generally think girls are skeletally mature at Risser 4. Boys, not so reliably, they may continue growing. So the growth spurt starts at Risser 0 once the triradiate cartilage is closed, and that is what we see right here, the socket of the hip joint. Then the next technique we can rely on for determining skeletal maturity is simple growth measurements. If the patient's height is carefully measured at every office visit, we can directly observe when growth stops, and that's when the height doesn't change over a year's time. The problem with this, I find in a clinical practice, is it seems to be surprisingly difficult to get consistent measurements. One nurse might measure the patient with the shoes on, one with the shoes off, one might press the hair flat, and the other might let the stand-up hair determine. Anyway, we see that there can be a variant of up to an inch in a year's time, even in a patient who hasn't grown. So even though it's a good idea in principle, in practice, it doesn't seem to work out as well. More sophisticated methods rely on, well, the classic is a Grulich and Pyle atlas of hand x-rays. So it turns out all of the small bones in the wrist and the fingers ossify at stereotypical times. And so if you get an x-ray of the hand and compare it against this atlas, you can determine with great accuracy the skeletal age. The problem with this method is that it's too cumbersome for use in a busy clinical setting. There have been a number of attempts, I just mentioned a few, at simplifying this principle, the Tanner-Whitehouse method, and then James Sanders has a simplified method that relies simply on the ossification of the growth plates in the fingers. So at stage 1, which is about the age of 9 or 10, the ossification has not started at all. So you've got immature growth plates. The shaft of the bone is wider than the growth plate. By the time what we're interested in, is at his 7th stage out of 8 stages, typically around age 15. By this point, all of the growth plates in the fingers have ossified. The only growth plate that really remains open is the growth plate in the end of the wrist bone. And it's when that begins to ossify that the patient is at stage 7, and we can reliably assume that the patient has ceased growing at that point. Another method from a group in Hong Kong uses a similar scheme, but relies strictly on the ossification of the ulna and the radius, the 2 wrist bones. When the radius is starting to, growth plate is starting to fuse, that's when ossification, or that's when skeletal maturity has been achieved. So to summarize, bracing can be discontinued when several criteria are met. This would include an age of around 15 or 16 in a girl. This would include 18 to 24 months after menarche. This would include a Risser sign of 4 or better, cessation of growth for at least 1 year, and finally, fusion of the growth plates of the wrist bone, as described here. Another question that comes up in discussing cessation of bracing is, how is bracing discontinued? Do you discontinue bracing all at once, or do you start a weaning program? And interestingly enough, over 90% of orthopedic spine surgeons in one survey report that they use a weaning schedule. To me, that's not logical. We know from the BRACE study that full-time bracing is effective and part-time bracing is much less effective. And we know with all of these measures I've outlined, we should have a pretty good idea when skeletal maturity has been achieved. So why would we make a patient wear a brace that we know isn't effective after there's no longer a need for the brace? But that doesn't comport with standard practice. I think still most surgeons do wean the brace, and a typical schedule would be 4 to 6 months of nighttime bracing alone. I've been asked to touch on complications of brace treatment, and we'll go over this very quickly. Fortunately, it's a short topic. There are physiologic complications and psychologic complications. Physiologic complications include potential chest wall deformity, and this is much more a problem for early onset scoliosis, so scoliosis in small children. In adolescence, the risk of a deformity from brace treatment is much less, except perhaps in the case of a hypokyphotic spine, and that's where the thoracic spine curves forward instead of curving backward like we expect. There, the pads of the brace might accentuate the deformity, but that's not a huge problem. Respiratory compromise is sometimes described. One study looked at pulmonary function at the onset of bracing, and then a year and then 2 years after bracing, and they found that although there was some compromise in pulmonary function early on, by the time of the 1 and 2 year follow-ups, that had largely normalized. So respiratory compromise isn't a major issue. Skin problems, this is sort of trivial but deserves mention. Chafing, rubbing, hyperpigmentation are all potential problems. They can be mitigated by excellent fit of the brace and by simply wearing a t-shirt under the brace. Some observers think there's a risk of bracing causing diminished bone mineral density of the spine. That's an interesting theory, but as far as I know, there hasn't been any evidence to support that as a risk factor for scoliosis bracing. Psychologic aspects of brace wear have been explored very extensively, and I've just listed a smattering of papers that address this issue. To summarize all of this, although in some studies there may be a prolonged deficit of body self-image in braced patients, other parameters are typically not affected by brace treatment long-term. And one interesting paper looked at quality of life of braced patients, and they found that in 9 out of 12 measures, the braced patients did better than US norms. So to conclude, I have briefly discussed the factors that go into the decision when to stop bracing, and I've touched very quickly on some of the risks and complications of bracing. The conclusion is that bracing is overall well tolerated, both physically and psychologically, and it can prevent the progression of scoliosis. Thank you for your attention.
Thank you very much, Dr. Fuller, for giving us that presentation. And now we come to the end where we have our Q&A session. I do want to thank Tammy, Maddie, Jennifer, Peter, Don, and Rosa for the questions they put forward. And again, for those of you that are on the line, if you go to the Q&A folder, you can either post your own question that we'll try to get to, and or like the ones that are there and determine what the priority is that you'd like to see the questions answered. I would summarize these questions. They really address age, style, and gender for many of them. So particularly with age, Dr. Weinstein, I would ask you, we have two questions that are asking, I have a 4-year-old, and on the other end of the spectrum, we have a 54-year-old male. So with both ends, what would be your comments regarding bracing for the 4-year-old and bracing for the 54-year-old?
Well, I think first we have to separate what we were discussing today was primarily adolescent idiopathic scoliosis, which has the onset by definition after 10 years of age. And most of the literature on scoliosis applies to this group of patients. When you talk about a 4-year-old, you're talking about what we now call early onset scoliosis. And while bracing is the standard of care, there's really good data because there's so much growth potential, and there's not really good long-term data on the use of braces in young patients. So for the mother or family who asked that question, it is the standard of care, but we don't have as high level of evidence as we do for adolescent. Now, on the other end of the spectrum, in the adult, very mature patient, in this case in the 50-year range, the expectations of bracing are very different because there's no expectation that the curve will get better or that necessarily can be stabilized. And more often than not, most braces in the senior population is used for pain relief or some type of conservative measure, particularly to relieve pain. So the purpose of bracing is very different in these two age groups. And again, the evidence is not at the high level we have for the adolescent group, which we'll be talking about tonight.
Thank you very much. And my apologies to Dawn, the 54-year-old was actually a female. And with regard, we had several questions, Luke, regarding other styles of bracing. In particular, the unique TLSO, the spine core soft brace, Scoliosis brace, and ProSpine by Hanger. And perhaps with those four, you could give us a comment about those particular braces.
Thank you, Joe, and appreciate the questions. There's no question that we are having the evolution of brace design, coming up with newer concepts and providing options for patients. So quickly, the unique brace is unique because it's a 3D printed brace. It's attempting to use new technology in the actual fabrication of the brace using different materials extruded with a 3D printer. It's pretty much a design that is consistent with current braces. However, it's a Boston brace typically with the posterior opening. And it has some really fancy cutouts and things like in it, but its function at the end of the day is basically very similar to other designs. So there's no improvement in its efficacy and effectiveness in getting curve correction. The ProScan is a brace that is an evolution from the Rosenberger, as Hanger had a employee that developed their spine program very extensively, and they came up with some newer concepts. So it's an evolution of the Rosenberger. It's an anterior opening design, and it will incorporate some Chanot style principles as well, but it's unique to the Hanger company. The spine core brace initially was brought into the market in the 70s and 80s, I believe. And Joe, you had some experience with that, and it had great promise. I think it was a difficult brace for the average orthotist to wrap their head around, and probably didn't understand the underlying concepts and principles. And the evidence didn't support its use by the outcomes that many of the orthopedists were disappointed to see. I think initially they were really excited about that. And so it's still used in a number of places around the world. I think it's particularly an option for smaller curves, curves under 30 degrees. It tends to be very reasonable and effective for those. It hasn't proven to be particularly good for bigger curves or curves that are more complex or progressing. And then more recently, we've had the evolution of the Scoli brace, which is again a brace commonly used by chiropractors. It's promoted by chiropractors. It really is an evolution of the Gomez or the Goss brace that's come out in the last 6 or 7 years. So there's different population of practitioners who are using these different brace types. And ultimately, as I was trying to convey in the presentation, the emphasis shouldn't be on the style of brace as much as it is the underlying understanding, knowledge, and skill of the individual who's using that brace, the orthotist or the physician.
Thank you, Luke, for answering those questions for us. And now, Dr. Fuller, the question on gender and timing of bracing, and in particular, we have Rosa that has a son, it appears, who's 9 years old with an 18-degree curve and is in a brace for 18 hours a day. And she questions how long he really has to be in the brace, both in terms of the hours that it's there, and whether or not the other question that came in from others was, can that be at different times? If we know it has to be at least 13 hours by the brace study, can that be nighttime wear and not during the daytime? And is it specific to the time of day that you have to wear that brace? I'm a 23-hour-a-day brace wear advocate. I think 18 hours, we know from the brace study, is likely to be successful. Less than that is not likely to be successful. There have been a few brace designs that are designed only for nighttime wear, and my understanding is that they're really not effective as full-time brace wear. The 9-year-old boy may be looking at 7 to 9 years of brace wear until he's somewhere around 15 to 18. Boys are still often growing at the age of even 18. But I think the brace study suggests that if he does wear the brace that long each day, he may well be able to prevent progression of his deformity. Thank you very much. Dr. I guess Luke actually will ask this question in terms of the use of the role of exercises and what's been found in terms of its use with bracing, and does it enhance it, and should that be promoted, et cetera?
Well, that's a really great question. I think as a SRS member, having attended SRS numerous times in the late 80s, early 90s, well, I'm sorry, in the late 90s, early 2000s, I came to the understanding that physical therapy had no real role in the management of scoliosis. And so it was out of my frustration with having patients with big curves, I started seeking other options. And I went to Barcelona in 2004 and I learned about Schroth and what they were doing in Europe. And that was the foundations of what became later the SOSORT organization. And the Europeans had a whole different perspective based on their experience about exercises, something that we kind of slowly, gradually started to listen to and then embrace, and first with skepticism, but more frequently now with great enthusiasm. So I'm really excited to say that over the evolution of the last 15 years in North America, scoliosis-specific exercises are taking a greater role, and it's because of our understanding and knowing that when we specifically address the scoliosis nature with exercises through one of those programs with trained therapists of very high competency levels, that work synergistically with the bracing process. So absolutely, we're seeing much better results, particularly on the larger magnitude curves, those 35, 45 and up. The key is, like anything, that it requires a high level of discipline and determination on the part of the patient to sustain it. And the role of the therapist is monumental, because probably more than all the rest of the treatment team, the therapist has more time and interaction with the patient. So I'm absolutely an advocate for physical therapy and working with scoliosis bracing patients.
Thank you, Luke. If you could just extend for one more time, we did have a question from an orthotist, actually, who was asking where could they go to get training in other forms of bracing, other than, I guess right now they're sort of limited to the Boston brace. And is there a place where they can learn about the others that's there?
Yeah, very good question. We believe strongly that scoliosis training needs to happen more in a mentoring level. It doesn't lend itself to a one day or a one weekend continuing education course like we see in many other realms, that it's more likely to be transformational in your knowledge and understanding whenever you really connect with another mentor and you work alongside of someone who has that years of experience. And that's the same model we see amongst surgeons, that the residents of fellows spend time with, and they have these traveling fellowships. And in that realm, you're much more likely to really grasp the complexity of scoliosis management. So rather than a single course, I'd say connect with what you might consider to be some experts. And there are a number of those, I think, that are available, and increasingly so. So I'd invite that individual to contact me offline if they'd like for me to give them some options to recommend, depending on where they are in the world.
Thank you, Luke. I'd also recommend that they seek out SOSORT so they can learn about all of the various options that are there.
Absolutely.
Dr. Weinstein, I'd like to go back to you. If we could ask a question a little bit deeper. I don't want to get into the particular case, but what about, again, patients in that early onset or juvenile, but patients who may have autism or be in the spectrum or have other conditions, and maybe casting and the difference between casting and bracing, and what can be expected, and what's your experience with patients and with that?
Well, I think that as many of the listeners may know, that autism is a spectrum of conditions, and excuse me, many children with autism also incidentally happen to have scoliosis, and that presents unique challenges for the treating team, the physician, the orthotist, and also for the family. And I think this has to be individualized. Some autistic children who are, and we're talking about early onset, may be amenable to a casting program, which prevents the cast from being removed. But for some, it may be totally intolerable, and bracing may be a better option. But excuse me, in any case, each child is so different that I think it requires a level of knowledge, intimate knowledge of the family, the patient, what the child will tolerate, and particularly when you're talking about early onset, which requires a long time of treatment to maturity. So it's not an easy answer, but again, has been emphasized, a team approach with your orthotist, your physician, orthopedic surgeon, et cetera, and family wishes all need to be considered.
Okay, if I could extend for you, Dr. Weinstein, just looking further, and we talked about what to expect for bracing, but if one of the questions that we have in here is, the child is now coming to the end of their skeletal maturity, they're at 48 degrees. What really can they anticipate for their child?
Well, I think, we've studied the natural history of untreated patients, and what we can say to families unequivocally, if the curve at maturity is less than 30 degrees, it will stay there for a lifetime. When you start to get to larger magnitude curves over 40 degrees, in my practice, and I think most practices, I think it's a good idea to keep in contact with your treating physician. And so when the child reaches maturity, we usually see them back and we extend the visits out. And usually in my practice, if the curve is over 40 degrees, I will tend to follow the patient for a lifetime, ensuring that there is no curve progression. I think many of the listeners tonight will know that in many practices, surgery is often indicated if the curve progresses beyond 40 degrees. And universally, most people, 50 degrees is a threshold. But if you have a mature child who's having no problems, has a well-balanced spine, then I think it's certainly acceptable to keep an eye on that youngster as they become an adult and monitor if they are having problems, if there is curve progression. I think surgery is indicated when the patient feels that it's necessary. And as a physician, I think we all feel we're the navigator, helping patients make choices which are best for them. So regardless of a number, it's more important to know how the patient is actually doing and to know whether that curve is impacting their life in some functional way. So careful follow-up, a good relationship with a physician and care team, I think, are best in helping patients make mature decisions when the curve has reached skeletal maturity.
Unfortunately, that's all the time we have for this evening. I would like to thank Dr. Weinstein and Lou Stikeleather and Dr. Fuller for their presentation, and to thank all of you for participating tonight. And again, to remember that this webinar will be available at that link that's on that last slide that you can see. And thank you again for coming. We appreciate it. Good night.